Assalamu alaikum and good evening to everyone. I am Dr. Nikhat Islam, Associate Consultant, Department of Clinical and Interventional Cardiology, Evercare Hospitals, Dhaka. Now I am going to present my case. A 41 years old gentleman who was normotensive and non-diabetic presented with sudden onset of breathing difficulty and chest pain for the last 3 days. He had no history of fever or chest trauma. His vitals was BP was 110 by 70 millimeter of mercury. Heart rate was 110 by 10 per minute, regular and bounding in character. His respiratory rate was 16 per minute. SpO2 was 98% on room air, and he was afebrile. On examination, he was conscious oriented, normal body stature, chest was clear. On CVS examination, thrill with both systolic and diastolic component was present at left parasternal border. Continuous murmur heard over the entire precordium. His ECG showed sinus tachycardia and X-ray was apparently normal. On echocardiogram, left parasternal view, it showed that aneurysmal dilatation of the right aortic sinus, which the final transthoracic echocardiogram interpretation was aneurysmal dilatation of the right aortic sinus of Valsalva, rupturing into the basal interventricular septum, then into the LVOT, resulting in the continuous flow into it. The aortic valve was trileaflet, aorticus are non-coapting, leading to the severe AR. The PHT was 112 mm/second, and hollow diastolic flow reversal seen in the proximal descending aorta. Tethering the mitral leaflet seen with fluttering of the ML because of the eccentric jet of the AR causing severe secondary MR. There was moderate TR, RVSP was 58 millimeter of mercury, and global hypokinesia of the LV, the ejection fraction was 35 to 40%. The CAG was done, which revealed normal coronaries. The patient underwent DVR with prosthetic aortic and mitral valve along with RSOV repair. His post-operative period was uneventful, and he was discharged in a stable condition. This was his post-operative echo showing repaired RSOV and the prosthetic mitral and aortic valves. This is the color flow imaging. I want to say a few words about the sinus of Valsalva aneurysm. In morphology, the malformation consists of a separation of lack of fusion between the media of the aorta and the annulus fibrosus of the aortic valve. The prevalence is 70 to 90% arise from the right coronary sinus, 10 to 20% from the non-coronary sinus, and less than 5% arise from the left coronary sinus. The etiology causes congenital, 0.1%, 3.5% of the congenital heart diseases.
You can
trauma.
Skip this and go to your diagnosis.
Okay. My diagnosis is the rupture sinus of Valsalva, which drained into the interventricular septum and then into LVOT. It is an extremely rare scenario. Rupture sinus of Valsalva in the Basal IVS, then in the LVOT.
That was a very beautiful case and presented well. Good.
Thank you.
Congratulations. I have one question to you.
Okay, ma'am.
What are the peculiarity in your case? We all know rupture of sinus of Valsalva, all of us we treat. What was very peculiar in your case?
Madam, it ruptured in the interventricular septum first and then it drained into the LVOT. That is not
it has burrowed into the interventricular septum.
Yeah.
But when it burrows into interventricular septum, invariably it will have complete heart block.
Oh,
we have seen the
present.
complete heart block patient dying suddenly, but in your case, ECG was normal.
ECG
that
was
is one
sinus
peculiarity.
Yeah.
The second thing is rupture of sinus of Valsalva, invariably it is into the RV or RA.
Yes, ma'am.
But here it is into the LV.
LV.
So
yes,
that is a very unusual thing.
So for that reason, I presented this case, ma'am.
And that's the reason I said it's a very beautiful case.
Thank you, ma'am.
Thank you very much.
Thank you.